This program is presented by University of California Television. Like what you learn? Help others discover UCTV podcasts by leaving a comment or rating for us in iTunes. Also, make sure to check out and subscribe to our YouTube original channel, UCTV Prime, available only on YouTube. This UCTV podcast is sponsored in part by Audible.com, your destination for the widest selection of digital audiobooks available, including many by guests you've seen on UCTV. Audible.com is offering UCTV viewers a free 30-day trial subscription and one free audiobook download. Just visit audibletrial.com/UCTV to sign up. And thanks.
Welcome to the University of California Davis Health System. Since 1973, continuing medical education, CME, has been an integral part of the educational mission of the UC Davis School of Medicine and Medical Center. The Center for Health and Technology, CHT, increases access to health education and promotes interaction between patients, physicians, and other healthcare professionals through the use of telecommunications and computer technology.
Hello, my name is Rita Hargrave. I'm a geriatric psychiatrist at the Martinez VA Outpatient Clinic, and the topic today is insomnia or sleep problems in dementia. At this time, I have no conflicts of interest or financial affiliations to disclose. Now, I would like to frame this talk with the same 4 take-home messages. This is what we're going to start with, and this is also how we will end. The 4 take-home messages are: it is critical to compile a comprehensive sleep history. That's that talk in the beginning where you really outline what is the nature of the person's sleep problem. 2, another critical piece is to identify arousal versus circadian rhythm dysfunction, and we'll talk about that later on. The 3rd important piece is to negotiate a family-oriented treatment strategy, because as many things in dementia, it's not just the patient. Any interventions, any treatment really involves engaging the families in the process of dealing with the problem, and in this case, it's sleep disorder. Finally, periodically reassess the results. So once you have done that initial sleep interview and outlined specific interventions, check in with the patient and their family to see if your interventions are working or if things have changed. Now, sleep changes in dementia are very common. Current research indicates that 40% of dementia patients suffer from sleep disturbances, and they're very common. These sleep disturbances can include difficulty falling asleep, nighttime awakenings, nighttime wanderings. That's one that I hear a lot. That's really disturbing to caregivers. Also, daytime napping, where the person spends most of the time in their easy chair asleep in front of the television. Another disturbing thing for caregivers. And finally, poor sleep efficacy. That is, they spend a substantial amount of time in bed but not asleep, tossing, turning, trying to get to sleep. So the hope is that your sleep efficacy would range in the 80%, so that 80% of the time that you are in bed, you are actually asleep. And there are many reasons why these sleep changes occur in dementia, make it much more difficult for people to get a restful night's sleep. Now, insomnia or sleep disorders have significant consequences, particularly in dementia, because we're talking about older populations. We know that insomnia in dementia has been associated with increased mortality, certainly worsening cognition. So, with a progressive cognitive decline that you would see in dementia, this is actually worsened a great deal by sleep problems. Increased caregiver burden, as I indicated before, there are several aspects of sleep disorders that caregivers particularly have trouble managing. Someone who sleeps all day, and also people who are up at night. Any sort of insomnia or sleep disorder in dementia may increase caregiver burden. And that increased stress on caregivers, that increased distress and burden may lead to the increased likelihood that the person will not be able to be taken care of at home, which takes us down the road to institutionalization or nursing home placement. Now, we think that there are 5 major causes of insomnia in dementia. The first one that I'd like to talk about are the neurophysiological changes. Dementia on its own has a series of brain changes that are associated with significant sleep disruption. As part of the process of degenerative decline, neurodegenerative decline in dementia, there's a loss of cholinergic neurons in the nucleus basalis. This, we think, is associated with reduced REM sleep. There are also studies that suggest that there's dysregulation in the suprachiasmatic nucleus. This is really the center for sleep regulation. And with that disruption, there are disturbances in sleep initiation. As I mentioned, people have a lot of difficulty falling asleep, getting to sleep. And we're not talking about 10 or 15 minutes. There are many people who will be awake for 3 or 4 hours before they're able to get any sleep on a regular basis. And some of that is physiologically determined. This dysregulation of the suprachiasmatic nucleus also is associated with problems in sleep maintenance. This may also result in people waking up multiple times at night. And finally, the last one, which is a problem for both institutional patients or patients who are cared for at home, circadian rhythm disorders. That is, people who become more confused, more restless, more agitated in the evening hours, which many people have indicated or have named sundowning. So both the loss of cholinergic neurons and the suprachiasmatic nucleus dysregulation are physiological changes in dementia that result in aspects of sleep problems. Finally, melatonin levels have been found to be lower in patients with Alzheimer's disease. So we have 3 neurophysiological changes that support this increased prevalence of insomnia in dementia. Again, the suprachiasmatic nucleus is the sleep pacemaker. This is what helps with both initiating sleep and also the maintenance of sleep. So moving on to the second major cause of insomnia in dementia. There are environmental and behavioral factors that interfere with people getting restful night's sleep. And most of the work that I do is really aimed at making substantive changes in people's environments and behaviors that can be very helpful in improving their ability to fall asleep and their ability to maintain a less disrupted sleep at night. So these are things that we actually address a great deal in the work that we do with patients. Now, the beginning of looking at these environmental and behavioral changes involves assessment, really getting a good understanding of what are the factors that are associated with the person getting to sleep at night. So the cornerstone of that is conducting a sleep interview with the patient, staff, and family. So these sleep interventions are not restricted to patients who are taken care of at home. They are very helpful with patients who are in hospital settings, who are in extended care settings or nursing homes, because these issues come up all the time. And in each of those situations, there are environmental and behavioral factors that can be modified. But it starts with that sleep interview. So in conducting that sleep interview, you're also looking to track over a 24-hour period their sleep-wake cycles, and beginning with that sleep, that diary, which is extremely important. Finally, developing a management plan in collaboration with the patient and their family or other caregiver to sort out what kinds of things can be changed. And again, looking to reevaluate the progress of these interventions and adjusting the interventions if they are not successful. But the cornerstone, again, is conducting a comprehensive sleep interview. Now, the beginning of that sleep interview starts with a presenting problem. And many times in patients with dementia, they may not be able to give you the full range of problems that are associated with sleep. Or you may have to ask, very probing, specific questions to get a sense of what kinds of sleep problems they recognize that they have. And the kinds of questions that you would be asking are directed at determining what part of their sleep cycle is most disrupted. So if we're looking at the beginning of the sleep period, asking questions about difficulty falling asleep. And again, we're not talking about 15 or 20 minutes of difficulty falling asleep. We may be talking about hours and hours of having difficulty falling asleep. The second part is looking at the middle sleep period, where patients will say they have difficulty staying asleep, where they will be up several times a night, maybe take a half hour to several hours to fall back asleep, and that this is a consistent pattern. Finally, waking up early in the morning. This is at the end of the sleep period, where people will say that they wake up before 2 or 3 o'clock in the morning and they are not able to get back to sleep. So really identifying if what we're looking at is primarily difficulty in the beginning of the sleep period, the middle of the sleep period, or the end of the sleep period, because your interventions will be designed to be effective based on the period of sleep that's actually most disrupted. Now, we also look at some of the forces that make it difficult, that promote sleep. So there are things like the circadian rhythms that are determined physiologically. There's also a homeostatic factor where as the day wears on, your body gets to the point where it needs more sleep. So those two things at the bottom, both of the circadian rhythms and the homeostatic drive or hunger for sleep, are things that drive you towards sleep. What can be disruptive to sleep are the arousal patterns and the behaviors. So those are often the focus of what we're looking at. How can we modify both the amount of arousal the person has and their behaviors to promote good sleep? Now, some of the causes of the arousal behaviors are sleep habits, what their environment is like, the medications that they're on, which is, again, for many older patients, they are on many medications that either are stimulating or cause significant side effects that interfere with their sleep. Looking at their medical and psychiatric comorbidities. And finally, though they're not quite as common, there are patients with dementia who have primary sleep disorders that need to be addressed in a separate way. Things like sleep apnea and REM behavioral disorder, which we'll talk about later. So we're really looking at what are the sleep habits, the environmental issues that may interfere with sleep, medications that people are taking, their medical and psychiatric comorbidities that may interfere with sleep, and also being on the lookout for primary sleep disorders. Now, in that sleep interview, after we look at the presenting problem, we also are wanting to examine what's the history of present illness. Now, the history of their sleep problems would start off with when did the problem begin, and if the patient or family have any thoughts about why this problem started at this point in time. Like, was there a precipitating event or factor? I see many patients who, when they are brought into nursing homes or into hospital settings, it's a completely new environment to them. If they're really cognitively impaired, they don't necessarily recognize or remember that they've been brought in for respite for the caregiver, that all they know is they are suddenly in a new place with new sounds and new smells, and it makes it very difficult for them to get comfortable. Increasingly, we see adult children moving their parents from a home they may have lived in for 50 years to move in with them, or to move into an apartment in a different state. And all of those things can play out in terms of people having worsening sleep problems that are connected with a specific factor or incident. There are also people, though, who've had long histories of sleep disorder that really haven't gotten addressed, and this is made more difficult for them to manage because of their cognitive impairment. Getting some background about a family history of sleep disorder is very important. And finally, when we're talking about a circadian type, is a patient a morning person or are they an evening person? So they call them larks and night owls. So a lark or a morning person would be somebody who feels best when they get up early in the morning. They may have always been somebody who rose before dawn and had their morning coffee. And then they will sort of peter out in the afternoon. On the other hand, then I think the people who are more problematic for anyone in an institutional setting are patients who have always been night owls. They've always been up awake 11, midnight, 1 o'clock. And when they were working or when their lives were more structured, they were able to manage on 4 or 5 hours of sleep. But if they're living in an institutional setting or living with someone else who doesn't have that same cycle, their natural sleep patterns of being evening persons can be very disruptive. Now, the third aspect of the sleep interview examines sleep habits. So we're looking at what kinds of sleep habits people have. This is what is going on now before we start our interventions. So in the beginning of the sleep period, the kinds of sleep habits that we're asking about is what time do people go to bed? Secondly, what time do they turn the lights out? And how long does it take them to fall asleep? It's not unusual for people to get in bed, maybe read, have the television on, have a variety of things that they're doing that may go on for 15, 20 minutes, maybe an hour before they actually try to fall asleep. And it's really important to determine how much time it takes between when they get into bed and when they actually fall asleep, and if there are things that are disrupting that. Also, what are their pre-bed activities? Are there things that they are doing that may be overstimulating? Watching war movies is a good example, or doing a lot of cleaning, or a lot of physical activity right before bed may be overstimulating. Also, are there pre-sleep arousal issues? If, say, an older adult with cognitive problems is living alone, as things get dark, as there are noises on the outside, are they overcome by fears, worries? Do they have issues with tension? Pain is another one, and pain is something that needs to be assessed at every point in the sleep cycle because it can be disruptive to every aspect of sleep. Also, post-traumatic stress disorder. As our older vets have more cognitive problems, it's not uncommon for nightmares and fears associated with prior combat to emerge as they get older. So really looking for symptoms of PTSD can be very helpful. Finally, thoughts and behaviors that patients recognize make it difficult for them to get to sleep. And those, again, may be fearful thoughts or worries. The last thing to look at is the regularity of people's sleep patterns. Do they go to bed at the same time every night? It's pretty classic for people to have a fairly regular cycle during the week, but then on the weekends to decide to sleep in late, and that sort of disrupts their entire sleep cycle. If people go on vacation or have time zone issues, their regular sleep cycle has been disrupted, and many times one of the first places it turns up is what time they go to bed and how easy it is for them to fall asleep. Now, if it looks as though the majority of the issues with their sleep problems are involved in the beginning of the sleep period, there are a number of things that can be done. That huge piece of chocolate cake, though appealing as it may actually be, may not be what you want to have right before you go to bed. So hot chocolate before you go to bed may not be the thing to do. So because chocolate has stimulant properties to it. the same way coffee does. So restricting caffeine intake, chocolate, coffee, alcohol and tobacco late in the evening, because all of those can make it more difficult for people to fall asleep. Second thing, to establish regular meal times earlier in the evening, to eat light in the evening. I know Miami is famous for their senior specials, and there's a reason for that. The digestive process becomes a little bit more difficult as patients get older, so having that meal in the 6 or at 7 o'clock at the latest can allow their systems to deal with digestion and not have that discomfort present or bloating as they're trying to fall asleep. Also, avoid excessive evening fluid intake and emptying the bladder before going to bed. And you know, a number of the men I see, of course, have urinary retention problems, prostatic problems, which can make it very difficult for them to get a non-disruptive night's sleep because of urinary issues. So really looking at that as a factor to consider, how can we behaviorally adjust people's cycles in terms of bladder function. Taking a close look at the medications, both what's prescribed and the over-the-counter medications that people take, to see if what they're getting interferes with their sleep. They may be able to tell you that if they take a particular medication in the morning, it tends to get them more energized. So that would certainly not be something that you would want to prescribe later on in the day. Reducing nighttime pain is a critical piece of it, and it might not be something that's easy to identify. I mean, there are several studies that have shown that in patients with dementia, they often have a lot of difficulty articulating the level of pain, identifying where it is, and there are several studies that sort of prophylactically use pain medications and found that the sleep disorders dropped dramatically. Even though people were not complaining of pain, it becomes so chronic that they thought of it as part of the landscape, and that reduction of pain made a huge difference in their nighttime behaviors. Finally, during the day, getting some level of moderate and regular exercise, again, to sort of help the body relax, wear itself out, but again, you know, several hours before you actually go to sleep. So to consider that or factor that in to some of the recommendations that can be made to help with sleep initiation. Now, looking at sleep habits that occur more in the middle of the night. Here again, we're looking at things like how many times do people wake up at night. Again, it's not uncommon for people, particularly with bladder problems or some pain issues, to wake up once or twice a night. So we're looking at not only the number of awakenings, but the total amount of time that they stay awake. You know, it's one thing to get up you know, at 11:30 or midnight and go to the bathroom, stay up for 5 minutes, and then get back to sleep. It's a very different situation if when you get up, it takes you 2 or 3 hours to get back to sleep. That's problematic. And what are some of the things, the thoughts and behaviors that occur in the middle of the night that make it difficult for people to fall back asleep? Could be anxiety, could be depression, you know, worries that come on in the middle of the night that make it difficult for patients to fall asleep when they do wake up. So some of the strategies that we recommend to help people who are awake in the middle of the night is, if they are having trouble getting back to sleep, for instance, if they get up and they climb back into bed, if they're not asleep in 10 or 15 to 20 minutes, they need to get out of bed. Because staying in bed, tossing and turning, focusing on how difficult it is to get back to sleep only makes the situation worse. So we suggest that people get out of bed after 15 or 20 minutes, and most of the time people know when it's going to be easy for them to fall asleep and when it's going to be a struggle. So we help them really recognize the patterns and think about what are going to be the strategies if they have trouble getting back to sleep. And some of the things we suggest that they do when they get out of bed is to engage in relaxing but boring activities. Things like sorting laundry. For some people, it's doing some light cleaning. It may be reading, things that they can engage in that will help them relax. For some people, it's a computer. Other people, that can be overly stimulating. And thinking about the things that you watch at night, maybe turning on music. But the main thing is to stay up until the person really feels that they're sleepy and they want to go to sleep. So to return to bed only when they're sleepy. And for some people, night lights can be very comforting. So again, we're looking at what are some of the things that people can do to improve the likelihood that they will fall back asleep and not spend the time tossing and turning in bed, worsening their sleep efficacy. Now, finally, what happens at the end of the night? We ask very specific questions about what is the final wake-up time that the person has, and what time do their eyes open. The second key question is, when do they get out of bed? Because there are people who will wake up and say, you know, I didn't feel like I got enough sleep, so I'm going to just stay in bed and hopefully I'll fall back asleep. So they may be in bed tossing and turning, trying to get back to sleep for another couple of hours, which usually means that they're still tired and irritable when they finally get out of bed. Looking again at the end of sleep, do they wake up early in the morning and they cannot get back to sleep? Looking at difficulties waking up at the time that they want to get up. Because I have often seen folks who say they have a regular appointment at a day treatment program, a senior center, during the week. So when they know that they have to get up for that, they're able to negotiate getting up. But on the weekends, they would like to be able to get up at the same time, but somehow there isn't the same impetus, the same motivation to get up. So they will sleep later, even though they don't want to. Finally, again, looking at the end of the night sleep habits, how much did they sleep throughout the night? So getting an estimated total amount of sleep. It may be disrupted, but really getting a sense of not how much time did you spend in bed, but how much time did you actually sleep. So if the problems seem to be occurring more at the end of night, to some of the things that can be done to help with end-of-night sleep problems is to establish a regular wake-up time, so that if you decide that you want to get up at 7 o'clock, no matter what has happened the night before, no matter how many times you got up in the middle of the night, to always get up at 7 o'clock, whether it's during the week or on the weekends. The second thing, once you wake up, to again get out of bed. That's it. Not to stay there and try and catnap and get back to sleep, but to get your system on a regular cycle when you wake up, you get out of bed. Also to monitor the average total sleep time. So this is something that needs to be done at the very beginning of this assessment and needs to continue all the way through, so that you and the patients and their family will have a sense of an improvement or change over time. Also to explore daytime contribution to a good night's sleep, because people can, as they start becoming more aware of how environmental issues and behaviors contribute to sleep, they will be able to tally up what are the things that they think led to a good night's sleep. It might have been more exercise, they might have had a pleasant day, there might have been someone else in the house that made them feel more comfortable, so that for them to identify what things help them get a good night's sleep. Also to find out what things make sleep more difficult, or what makes a bad night's sleep. The patients with more significant impairment may not be able to identify those factors as well as a caregiver, but a caregiver can be very helpful in identifying what are the factors that promote a good night's sleep. Finally, naps can be an issue for people, because many times, as I mentioned before, there are patients who will spend most of their day sort of asleep, catnapping in an easy chair. Naps are okay, but it's really important to limit the number of naps to at maximum 1 a day. Maybe 2, but 1 is really optimal. And that nap should be for no more than 60 minutes, and we actually prefer more in the 20 to 30 minute range. And it should happen, in the early afternoon, before 2 p.m. The reason I say this is that if you nap during the day, say if you take 2 half-hour naps, you're robbing your body of that hour's worth of sleep at night. It's very much like snacking. So if you plan on having dinner at 7, if you had a piece of cake at 4, and then you had a salad at 5, and then you had a piece of bread at 6, by the time 7 o'clock rolls around for dinner, you probably are not going to be very hungry. So you will have reduced your drive for food, your hunger, because of that chipping away, those snacks. So these naps are like sleep snacks. And we want to be sure that when you get to bed at night, or when the patient gets to bed at night, they are hungry for sleep. So that's sort of how I put it to patients, and most people sort of understand that concept. So if naps are there, they really should be limited to no more than 60 minutes, preferably 20 minutes to 30 minutes, and then those should occur early enough in the afternoon that they will not disrupt nighttime sleep. Okay, another part of sleep interview looks at the environment that contributes to a good night or a bad night's sleep. Some environmental factors are difficult to control. We've got the barking dog, we have lights that are on in the house or street lamps, and we have temperature. Some people like a very warm room, other people like a very cold room. And I see this often when people go into institutional settings, hospitals, nursing homes, rehabilitation centers. They don't have the capacity to necessarily make changes in the noise level. You know, nursing staff at night, maintenance people at night that come through. There's often a lot of complaints about laboratories that are ordered, blood draws that are ordered, or blood pressures that are taken in the middle of the night, even if it isn't the patient themselves. Maybe their next door neighbor is getting some sort of nighttime monitoring. Not having the capacity to control the temperature or the light within a room. All of those things can make it more difficult to sleep in a new environment. Now, medications, both over-the-counter and prescription medicines, are an evaluation of medications that may be interfering with sleep, are really a critical piece of understanding and making adjustments around people's sleep disorders. Now, there are many medications that have sort of untoward side effects that can be very disruptive to sleep. Antihypertensives, because of the diuresis, that would mean the person would be up in the middle of the night going to the bathroom more often. It's kind of a necessary evil, but that can be very disruptive to folks. There are some antihypertensives that make people drowsy, so that if they take those first thing in the morning, that may make them more prone to take naps during the day. Many of the medicines that are used in psychiatry, anxiety medications, antidepressants, like the serotonin reuptake inhibitors like Prozac and sertraline that are commonly used, they actually decrease the amount of REM sleep that people actually get. So they make significant changes in the sleep architecture, which if someone is healthy and able to sort of manage that, their sleep won't be disrupted. But for our older adults who already are having a lot of difficulties because of the neurophysiological changes associated with dementia, the disrupted sleep architecture associated with serotonin reuptake inhibitors can be very problematic. In terms of analgesics, again, we get back to the issue of pain. There's been a lot of work that's looked at how undertreated pain is in many older adults. And as indicated before, older adults with cognitive problems may not be as likely to report pain. They may be less likely to remember to ask nursing staff for PRN medications for pain. So they are suffering from pain and we don't even know that. Finally, cholinesterase inhibitors, the ones that we're using for dementia, and levodopa, and those dopaminergic agents that are used for Parkinson's disease, also have a major impact on the sleep architecture, that there's decreased REM sleep, people report more vivid nightmares and dreams. So these very commonly used medications all need to be assessed to see if some adjustment in their levels or the nature of the actual agent can be changed to improve people's sleep. Now, some of the stimulants that are used, sometimes they will use Ritalin, for instance, to help with appetite and energy with dementia patients, or other sympathomimetics may delay sleep onset. I know bronchodilators can delay sleep onset. I see a real rash of sleep problems, increased anxiety around allergy season with people who have an allergic component to their congestive obstructive pulmonary disease. So people who I work with who are not having sleep problems, who are doing fairly well, as they start using their inhalers in the springtime, will report more trouble with anxiety, more trouble with fatigue, and more trouble with sleep. And we mentioned before that the anti-Parkinsonian agents, the dopaminergic agents, have been associated with nightmares, hallucinations, and daytime sedation. So again, working, if you're at all able to connect with a pharmacist to look at what are some of the agents that have been implicated in worsening sleep disorders, and seeing if there can be adjustments made to those medications. Now, one of the things that we do use are agents to help with sleep, because many times patients will come in and they basically say, I want a sleeping pill. They're not as motivated or interested in these long sleep inventories, or that's their perception of it, because they see the answer as being pretty simple. It's just a matter of getting the right sleep pill. And for older adults in general, we do use these agents, but it comes at a cost in some cases, because there are side effects associated with all of them, even at relatively low doses. As you can see, trazodone, which is one very commonly used in psychiatry, has been associated with orthostatic hypotension, and at higher doses, priapism. Any of the benzodiazepines like the lorazepam, even the short-acting ones like temazepam, have been associated with confusion, lethargy. They can be very problematic with folks who have gait instability, that they can worsen people's gait and contribute to falls. Ambien or zolpidem, which is very short-acting, for some folks can still cause sedation, even though it's a very short-acting medication. Less often used for sleep, but certainly used for behavioral management issues, risperidone, olanzapine, and quetiapine. Again, they may cause a certain amount of daytime sedation, orthostatic hypotension, and dizziness that can be very problematic with people with gait instability. Substance use. Again, even though somebody is 70, 80, or 90 years old, the issue around substance use still needs to be addressed. And it's not all, includes some of the things we commonly think of as commonly abused substances: caffeine, alcohol, nicotine, but also recreational drugs, because increasingly we're seeing older adults who have been using cocaine, heroin, and prescription pain medications that for years, and those habits and those addictive behaviors continue into their elder years and can be disruptive in terms of sleep. Now, the last thing that we're looking at, or next to the last thing we're looking at, are primary sleep disorders. These are not the physiological sleep issues that we've talked about before, but specific sleep disorders that need special interventions. The four main ones that I would encourage people to evaluate and get background information on in that sleep interview are obstructive sleep apnea, periodic limb movement disorder, restless leg disorder, and REM behavioral disturbance, because these are all primary sleep disorders which occur in the elderly, and I think the more that we ask about these issues, the more commonly you will actually find them in your practice. Now, the kinds of things that you will identify in terms of symptoms of obstructive sleep apnea are snoring, excessive snoring. And I often get stories from patients where they say that the wife or a partner long ago moved into another bedroom because their snoring was so loud. And if you ask the caregiver or the wife, they will say, I've seen him stop breathing, I've seen him gasp. We've seen it happen in nursing homes and assisted care facilities, where a person for the first time in many years is actually sharing a bedroom, and the partner or the roommate will talk about how much that person snores and is keeping them awake at night. The other key piece of obstructive sleep apnea is that they have a very difficult time getting going in the morning. They're irritable, they have headaches, so they report a lot of daytime sleepiness. So if you suspect an obstructive sleep apnea, it's really key to get evaluation in a sleep lab to confirm that diagnosis. In the process of treating obstructive sleep apnea, weight loss in many of our patients is a critical factor in improving their ability to breathe well at night. Also, the avoidance of alcohol and hypnotics is also a critical issue. The kinds of benzodiazepines that we might use as sedative hypnotics would not be appropriate with someone with sleep apnea, because it will again reduce their drive to breathe at night. And last but not least is the use of the CPAP machine. The CPAP machine, which has really been found to be helpful to many patients, can be problematic with people with cognitive dysfunction. Their understanding of the need to use it, their memory of using it every night can be impaired. So people may not use it every night. It's really important to coordinate with the caregiver that adherence to the CPAP utilization is key to their having a better night's sleep. So no matter how expensive the CPAP machine is, if it's not being used, it really is useless. So looking at how the caregiver and the patient understand the use of the CPAP machine, helping identify what may be done to improve compliance with the use of it, is part of the ongoing monitoring of the use of the CPAP machine and its efficacy in sleep apnea. Now, periodic limb movement disorder. This involves getting a history that suggests repetitive limb movements that occur in sleep and really cause a great deal of disruption, both in people getting asleep and staying asleep. And these movements usually involve jerking or a lot of restlessness in feet, legs, ankles, and knees. It's often worsened by certain classes of antidepressants, antihistamines, and some antipsychotics. If there is that history, and it may be history that patients give, it may be history that family members or other caregivers will notice. It may be something that nursing staff will see in a hospital or a nursing home setting, that they will see that this person is having a lot of jerky movements at night. The treatment is often the medications that are used in Parkinson's disease. In some cases, anticonvulsants have been useful, and also benzodiazepines. But it's a very unique sleep disorder, periodic limb movement disorder. Restless leg syndrome has become a focus of a lot of attention because it has been found to be more common in certain types of dementia. We're seeing it in Parkinson's related disorders. And I will often ask patients, do they ever get the sense that their legs are aching or tingling? Is there a sort of a creepy, crawly sensation that they get in their legs that can only be relieved when they get out of bed? And many times people will recognize that as a discomfort that has become part of their natural sleep routine. They'll also report they feel tired during the day and they have a lot of trouble sleeping. So if you're sort of hearing that subjective sense of aching, tingling, or creeping sensations in legs, you may want to think about restless leg syndrome as being the culprit. It has more of an autosomal dominant inheritance, and it seems to be more common in women. Certain other medical conditions often go in line with it. So low ferritin levels, antidepressant use, renal failure, rheumatoid arthritis, and peripheral neuropathy have all been found to be associated with restless leg syndrome. The treatment, again, is fairly specific. It's been found to be effectively treated with clonazepam, and other cases iron supplements, cimetidine, carbamazepine, bromocriptine, and temazepam. So the treatments are very specific, and I think the symptom picture is something that patients can identify pretty easily. Now the last one of the most interesting ones, is REM behavior disorder. Here in this case, the normal situation where the body's sort of paralyzed in the process of a nightmare, so that those nightmares are not acted upon, goes away. So as people go through dreams, they physically reenact those dreams. They're up, they're moving, people get up and walk. It can be idiopathic or secondary to a specific neurological disorder. Now, REM behavioral disorder has become much more on the table because they found it's been associated with Lewy body dementia and with Parkinson's disease and Parkinson's dementia. Also, certain antidepressants and beta blockers seem to also aggravate REM behavior disorder. Treatment in this case would be clonazepam, levodopa, the dopamine agonists, and melatonin. Now, finally, as part of the sleep interview, looking at the medical and psychiatric comorbidities that can interfere with sleep. Back to chronic pain. Chronic pain, chronic pain, chronic pain is something that really needs to continually be thought of as part of one of the major factors that contributes to poor sleep in dementia patients, in geriatric patients in general. But I think particularly it's an issue in dementia patients, as I've mentioned before, because their ability to assess and communicate the level of pain may be impaired. Congestive heart failure and benign prostatic hypertrophy with its associated urinary issues we've discussed before can be very disruptive to sleep. Renal failure, chronic obstructive pulmonary diseases. These are very common illnesses that are associated with sleep problems, and there are things that can be done to manage those illnesses to improve the person's sleep experience. Psychiatric comorbidities. Depression, anxiety, including PTSD, have both been associated with significant sleep disruptions, and if those illnesses are not treated, they can continue to disrupt people's sleep. In most cases, if there's a careful evaluation of the current antidepressant treatments and the anxiolytics that are being used, there can be some adjustments made to make the person's sleep experience more positive. Also, schizophrenics and bipolar disorder patients may have had a lifetime history of sleep disorders, so trying to sort out what environmental and behavioral factors can be modified to improve their sleep issues. Now finally, we're sort of at the end of the talk, but again, to sort of reinforce what are the most critical pieces of managing sleep disorders in the elderly with dementia. The cornerstone of whatever is done is based on compiling a comprehensive sleep history, really going through systematically, getting a sense of what are the current sleep problems, what's the sleep history, where in the sleep cycle the majority of the problems tend to lie. And the patients, and it's not uncommon for patients to both have trouble with falling asleep, trouble staying asleep, and also they may get up and not be able to get to sleep. So it's not uncommon for people to have problems in all of those areas. But what you can do is ask them which of those aspects do they want to tackle first. And it's very interesting that if you can sort of get some buy-in from patients to address one aspect of their sleep disruption and make some changes, then they will down the line be more willing to make other adjustments, they and their caregivers. But everything flows from compiling a comprehensive sleep history. Second, identifying the arousal disturbance factors. Remember our graph before with the arousal disturbances in yellow that were working hard against both circadian rhythms and homeostatic forces to promote good sleep. So really looking at what are some of the things in the person's environment or medications or medical comorbidities that will increase their arousal, that make it difficult for them to fall asleep and to stay asleep. Third, since every part of this, from the history taking to the assessment of comorbid medical problems, to the strategies that are arranged, really do involve patients and families. They may have to make some adjustments or changes in what they do. They may be the ones who will be your greatest allies at home to encouraging people to follow through with the recommendations that you've actually made. Could be anywhere from not having that extra piece of chocolate cake at 10 o'clock at night to using their CPAP machine. Your family is your greatest ally in promoting good sleep habits and implementing the treatment strategies that you feel will be most effective in helping people get a good night's sleep. Finally, periodically reassessing the results. It's very common to maybe get, I think for me, I found that helping with sleep initiation has probably been the simplest issue to deal with. Many people can make some relatively minor adjustment in their daytime and evening activities and begin to fall asleep faster. But for instance, if I see them, a week, a month, or 2 or 3 months later, there may have been some change in medications that they're taking. Their pain levels may have increased for whatever level. They may have come back from surgery. So the issues that were, there are new issues that arise that maybe staying asleep is an issue because the pain is arising at a later point in the day. So again, making adjustments around what the nature of the sleep disorder is and defining new strategies to improve their sleep maintenance and their sleep initiation. It's kind of it's an ongoing dialogue in terms of how one manages sleep disorders. And again, I want to thank you all for being present for this talk. I think you'll find that there are some very useful strategies that you can engage with family members and patients around how to best manage sleep disorders, insomnia in older adults with dementia. Thank you.